for the audience, what other cases should they expect a high thrombus burden beside a STEMI? I mean, is it only STEMI, or do you have any other cases that whenever you get a patient like this, it's like, wait a second, this is going to be a thrombus?
Yeah, so our focus here is coronaries. The other major coronary situation is the vein grafts, right? So we very frequently see no reflow, and when you have a vein graft, whether STEMI or NSTEMI, typically they're large vessels, and because they're venous structures, they're not intended as arterial conduits, they are absolutely predisposed to fill with thrombus. And so I will tell you, I have a bias in vein grafts pretty early on to pull out thrombectomy, and I really prefer mechanical thrombectomy as opposed to manual thrombectomy in vein grafts, just because of the degree of thrombus burden. I think, the 25 cc's that you can pull out into a pronto priority 1 export syringe might not be enough. You need continuous suction for the length of the vein graft. So in those situations, I lean on thrombectomy more heavily. More broadly, I think the larger the vessel is, if that is occluded, the higher the thrombus burden is going to be, and so the more likely you are to benefit from removing it. And whether that's done manually or mechanically, you got to get a lot out.
Yeah, and other cases like an old stent thrombosis, acute stent thrombosis, especially if the patient had a covered stent, those are usually thrombose with vengeance. And of course, late presenting NAMI, the patient's been having symptoms for weeks or two. Routine, we agreed on it, class 3 indication. SCI, you are the chair of the SCI guideline and standards, and the SCI consensus paper had a little of a twist to it. So, it's still agreed, routine is class 3, but they had 2B for selective high thrombus burden cases.
Yeah, so the SCI expert consensus statement, right? It's not a guideline; it's expert consensus, and that's important. It doesn't go through a guideline methodology, but the recommendations are that, in terms of managing thrombus, are essentially 3 things: angiographic assessment of the thrombus burden after the wire crosses the lesion, so hopefully you have some amount of distal flow, you get an idea. Bailout aspiration thrombectomy in cases of a high thrombus burden is an acceptable treatment strategy. The air quotes, because you can imagine what the conversation looked like on that Zoom meeting as people debated, what do we do to recommend or not recommend this technology? Some people say, like you do, it's my go-to. That's how I get the thrombus out so I can see what the coronary looked like. And some people, like me, say, no, it's a bailout. I only do it if I can't get the thrombus out with a balloon. And so, they couch it by saying it's an acceptable treatment strategy. And then, emphasis on IV and potentially intracoronary antithrombotic agents, antiplatelet agents in particular, for refractory thrombus. So considering thrombectomy for large thrombus burden, but plenty of room for the individual to make a decision. And I think, that's the spirit of the class 3 for routine use, right? We don't use it routinely. We just have that conversation. Certainly for futility, maybe for harm in terms of stroke, as we saw in total, but there's clearly a role in terms of bailout use and potentially upfront use in high thrombus burden. And those are important to maintain and to acknowledge. Outside the coronaries, there's a lot of excitement about thrombectomy, right? There used to be a period when we treated pulmonary embolism with heparin, right? And then there was a period when we treated pulmonary embolism with systemic thrombolytics. And then we came up with catheter-directed thrombolytics, right? Turns out you could just put a pigtail catheter with 8 side holes in and infuse lytics. And then somebody came up with the idea that maybe you could get more lytics in if you added ultrasound to cause those lytics to penetrate. And then the folks at Penumbra and Inari said, well, I guess we can suck that out too, right? And so that has really moved to the forefront. So I think we're seeing thrombectomy picking up speed, certainly in the lower extremities, in arterial spaces, in venous spaces, in the PE space, in pulmonary vasculature. And so the coronaries, they remain a less well-determined space for the role of thrombectomy, but it's clear there is a role, and that thrombectomy is not going away and should not go away.
the leading force behind thrombectomy, it was not PE, it was not arterial, it was stroke. We learned from stroke, and I think this is just the same story. And I think PE, because there was no ever a class 3 indication, so we're still using it even though there's no guidelines. I mean, the guidelines is going to be written at the end of this year, waiting for, Stone PE just came out, Hypitho coming out, Peerless 2 is coming out, so hopefully that can change it.